Well, good morning and welcome to CSIS, and a welcome to those who are joining us online and those who are coming in via C-SPAN and elsewhere. It's a real honor to be here today to welcome Dr. Jim Yong Kim, President of the World Bank, to speak on how to better prepare ourselves for future outbreaks in this era of the new normal of recurrent outbreaks that we've seen, SARS, H1N1, Ebola, now Zika. I'm Steve Morrison. I'm the Senior Vice President here at CSIS, and I direct our global health work. Just a few minutes of opening remarks. Dr. Kim has been President of the bank since 2012, and in that time has used his leadership quite strategically to bring about many changes, both internally and externally. He's positioned the bank to be a lead player, a key player in pandemics, in supporting refugees and humanitarian emergencies, in elevating attention to women and children, including childhood stunting, and in dealing with natural disasters and climate change. On the health front, he's enlisted Tim Evans to head the health practice and has established universal health coverage, UHC, as a central prism for looking at how low and middle income countries are to expand coverage, access, and quality in a fiscally sustainable way and eliminate catastrophic costs for individuals. UHC is the future. It's a sea change that's unfolding now, and the bank is at the forefront, thanks to Dr. Kim's leadership. His tenure has been exceedingly busy. In fact, his staff look kind of beat at the moment, returning to Washington after this recent whirlwind of the World Humanitarian Summit, Women Deliver, the G7, the finance ministers meeting, and on and on. We were all very late to awaken to the Ebola crisis in 2014, but there were some very important exceptions. We saw Dr. Kim very much in action during the darkest hours of the Ebola crisis in the summer and fall of 2014, and in the period of recovery that followed. We saw new emergency facilities put in place to hold these three states, Sierra Leone, Guinea, and Liberia, together as the bottom fell out fiscally, as trade, tourism, travel, and investment were gravely disrupted and as production declined. The bank was really central to that effort. It was a very dangerous period for West Africa and the world, which could have been vastly worse if the bank and others, most importantly the Obama administration, had not taken matters into their hands to forge ahead amidst a gathering chaos. We heard Dr. Kim's loud, critical voice early in the crisis, and we witnessed the careful tracking by the bank of the economic consequences, including right here in this room, where we had a number of meetings in which the bank was detailing what it was observing and learning. Subsequently, there were no fewer than 4 major retrospective analyses of what happened during the Ebola catastrophe. I had the honor of participating in one of those, the Harvard London School independent panel. The 4 panels converged in several key points: the need to invest in key capacities, in national capacities in low and middle income countries, the need to reform WHO, the need for new mechanisms for R&D, and new capacities for quick response. These studies all repeatedly cited the bank's innovations and early actions as critically important. One of the questions that these studies all begged was, will anything really follow? Will anything really happen from what we've learned from the Ebola catastrophe? And where will the political leadership come from? And one answer to these tough questions is what is on the table today. Something has happened, the Pandemic Emergency Financing Facility, and there has been high-level political will in the form of Dr. Kim and his colleagues. We'll be addressing today the bank's Pandemic Emergency Financing Facility, which was launched by Dr. Kim at the G7 Summit just a few days ago in Japan. Special congratulations are in order to Dr. Kim and his colleagues, most notably Tim Evans, Keith Hansen, Priya Basu, Mukesh Chawla, and others, for persevering over the past year and a half, for learning systematically from Ebola, and for creating a new tool to provide swift financing in the early stages of an epidemic to stop the outbreak while it is still in manageable proportions. We could never have gotten to this point where we are today were it not for Dr. Kim's dogged determination, leadership, and commitment, and the full resources of the bank in terms of its expert personnel and its financing acumen. It's an impressive achievement in the midst of all the other demands faced by the bank. We'll be discussing today what's required to put it together and make it fully operational over the course of the day. We'll need to be patient and realistic about the work that's still outstanding and bringing about full financing, getting it priced in the marketplace, making it operational. And we'll hear about the way it's been structured. We'll also hear about why this matters to U.S. national interest and to U.S. global health security approaches, particularly the U.S.-led global health security agenda. And I think we'll also, I hope, come to discuss how we need to build on what's happened at the bank and elsewhere, looking forward into the future. There are many other gaps that we need to think about. We're thrilled to be able to host Dr. Kim today. We're grateful, especially grateful to a close friend and colleague at the bank, Carolyn Reynolds, for making this possible. And special thanks also to Lizette Emma Cohen and Melanie Mayhew, both friends at the bank. On our staff here, special thanks to Joe Jordan, Sarah Allender, Chris Millard, Anya McDermott, and to Travis Hopkins, who's keeping the sound and light together for us today. We're going to hear a presentation by Dr. Kim, then we'll have a brief conversation, and in the course of that conversation, we'll be turning to you for your comments and questions. We'll need to break promptly at 12 noon, so please bear with us if we don't get to everyone's questions and comments. So please join me in welcoming Dr. Kim.
Well, thanks so much, Steve. It's great to see everybody here. I want to, first of all, thank Steve and CSIS for continuing to put global health on the agenda. It was many years ago when I first came to CSIS to talk about HIV and TB, and a place with the kind of reputation of CSIS to have put global health on the agenda so long ago is really critical. This is new for us. Let me just grab some water here. This is new for us in the sense that we've been in the business of creating new instruments against disasters for some time, but in terms of really taking on pandemics through an insurance policy, this was not easy. The discussions that we had, the technical consultations, we have been in conversation with CDC from the beginning. WHO has been a critical a part of this discussion as well. And so I just want to take you through our overall reasoning behind why we put this together. First, the central mission of the bank is to end poverty and boost shared prosperity. But in the face of trying to end poverty and boost shared prosperity, we have learned that economic growth alone will not do the job. In other words, if you look back on the last 15 or 20 years, poverty has dropped, and we're probably now below 10% of the global population living in extreme poverty for the first time in history. And of the number, the billion plus people who've been lifted out of extreme poverty, our researchers think that probably 2/3 of that was due to just pure economic growth. But then fully a third of it was due to other factors. And now we're fairly certain that risks like sluggish economic growth, as many of you know, the commodity supercycle is over. We just published some data suggesting that commodity exporters' growth rates over the past year dropped from 2.5% or so close to zero. Now, the commodity importers are still doing very well in the world. The commodity importers grew at almost 5% last year, but the commodity supercycle is over. It's not clear that it's ever going to start again. Access to capital is much more difficult, and growth is down. We just heard that Brazil shrunk 5.4% over the last year. Forced displacement. Again, this is an area that we haven't been involved in, but there's been a deep understanding now that the so-called refugee crisis lasts anywhere from 10 to 20 years. And what Antonio Guterres and Filippo Grandi, the two high commissioners for refugees, have been telling me is that there's no question that now they're involved in development activities. And they have told me that they're unqualified to do it. They want to work with us. And so we're at the beginning stages, but we raised about $1.6 billion in guarantees and concessional lending for the MENA region, specifically for countries like Jordan and Lebanon, who are hosting refugees. And the hope is that by engaging in development activities, creating job opportunities, we might have an impact on the humanitarian crisis in a way that has not been thought of before. Climate change, many of you may know the COP21 agreement was critically important. We are now, and by 2020 will be even more so, the largest funders of climate change activities in developing countries. We committed to $29 billion, but the last 7 months that have been the hottest of the last 7 months, the hottest December, I think starting in November, December, January, all the way through April. Each of those months have been the hottest in history. And we are seeing now changes that we thought would happen at higher temperatures happening now. This is a major threat to ending poverty, boosting shared prosperity, and of course pandemics. A survey, a Towers Watson survey of 30,000 insurance executives came to the conclusion that it was pandemics that was the biggest threat to their business and they thought to the world. And Steve mentioned it, and I'm glad he did. Childhood stunting is of proportions that we all should be really, really worried about. And it is even more worrying when you think about the paths toward economic development that will be open. Every forward-looking, every look at the future in terms of the paths of economic growth that will be open suggests that the traditional the low-skill, low-wage jobs, agriculture, light manufacturing, may not even be open to many developing countries. And so we're making the argument now that in an increasingly digitalized future, one of the determinants of potential economic growth, in addition to roads and other kinds of hard infrastructure, we think that gray matter infrastructure is going to be key in determining the potential economic growth of any country. Now, Larry Summers and Dean Jameson have been extremely helpful in making clearer the connection between health outcomes and economic growth. 24% of growth in full income, which just means actual economic growth plus the increased number of years of productive life. 24% in low and middle income countries between 2000 and 2011 were due to better health outcomes. Now, in going forward, and I've been in this room talking about other epidemics, and going forward, one of the things that we know for sure is that we're going to have to think differently. We're going to have to approach problems very differently than we have in the past. And we've taken the idea of thinking differently pretty seriously at the World Bank Group and published a year ago our World Development Report basically on behavioral economics. It was called Mind, Society, and Behavior. And it was a bit of a painful process to go through because there are some fundamental assumptions that economists make, and the most fundamental assumption is that people are rational actors and they make rational choices. They weigh their choices, they consider all available information, and they make decisions individually. The main findings from our World Development Report were that, in fact, people think reflexively, they think very quickly, people think socially, in other words, they're very much influenced by what the people around them think, and they think according to mental models, that they go in with preconceived notions, and it very much affects how they come to conclusions. And in order to illustrate this, we actually did an experiment on ourselves. We took World Bank employees, we got the same data set, and we asked them to evaluate the data set when comparing two kinds of skin cream. And when they were comparing two kinds of skin cream with a data set, they did extremely well. They got the right answers just about every single time. In other words, they interpreted the data correctly. But when we asked a different kind of question that was based on a minimum wage, right? A lot of people in the bank had preconceived notions about social protection programs and minimum wage, and with the same data set, comparing two programs, they got it wrong much more frequently because they didn't have preconceived notion about one skin cream or another, but they did about minimum wage programs. So this is very real, and I have experienced this very directly in my previous career around HIV. And many of you will remember, it was here in Washington where we had the most difficult debates on this, and there were great heroes, and I hope that they're here, some of them, who in the face of all this naysaying about the possibility of HIV treatment in Africa, stood up and put forward programs that have changed the world. PEPFAR is one of the programs that have truly, truly changed the world. When in January of 2003, when President Bush made the announcement, I think back to that date, and I think is there any chance that Africa would have grown at an average of 5 and 6% over the past 10 years if we had not made that decision? And I can't see how it would have happened, because and I'm glad some of the young people here don't even remember a time when we seriously considered the idea that the 25 million people living with HIV in Africa would all just have to die. I mean, that was the conclusion, the strong conclusion based on just about what everyone in the global health community thought. There were activists, and in the Bush administration, there were tremendous heroes who stood up to this and began treatment. So. I mean, it's just almost amazing to think about what people were saying at that time. The head of a very important agency said that many Africans don't know what Western time is. You have to take these drugs a certain number of hours each day or they don't work. Many people in Africa have never seen a clock or a watch their entire lives, and if you say 1 o'clock in the afternoon, they don't know what you're talking about. They know morning, they know noon, they know evening, they know darkness at night, so they can't possibly even begin to think about taking HIV drugs. We actually said stuff like that, but it was not just certain individuals, it was just about everybody. And so what happened with HIV? I think there were important lessons. Now 17 million people on treatment, and I'll never forget, because I was at WHO and we were involved in the so-called 3x5 movement. We were just taking the pledges like PEPFAR and trying to establish a target so that we would work differently. And people yelled and screamed in my face, "You are telling lies, it's impossible, there's no way they'll be on treatment." 17 million people on treatment today. Death rates have gone down, but we've still got a problem. Of the 37 million people living with HIV, 19 million don't know their status. There's still work to do. But I want you to get a sense of how incredibly concrete and incredibly powerful the mental model was at that time, that HIV treatment is not possible in developing countries. So now we have Ebola. And when I went to the World Bank, I thought that responding to these epidemics was no longer part of my responsibility. And so we have to ask, how did it happen? How did we let it happen once again? And here are the numbers, of course, and you see the timeline here. It was about at the end of July. I was actually spending 3 weeks in Asia. My family was there, and we were visiting many different countries. And I just kept seeing more reports. And then finally, at the end of July, I called some of my friends, infectious disease doctors, people like Tony Fauci, Tom Frieden, Paul Farmer, who I've worked with for years. And what I heard from them shocked me. They said, "This is the worst thing we've ever seen." I mean, Paul was saying to me, "There's just so much virus out there now, and we've never seen anything like this." And we were thinking, well, what if this goes to Karachi? What if this goes to Delhi? What if this goes to huge population centers where they're unprepared? It did go to Nigeria, and thanks to aggressive CDC action, thanks to the fact that the polio eradication folks had been so effective there and then converged on this problem, it was brought under control. But I'm going to show you a slide about what might have happened if we hadn't been able to react that quickly in Nigeria. So I think that we're still working with mental models that hamper our ability to have high enough aspirations. Look at, we've had report after report after report. My friend Harvey Feinberg, after bird flu in the 2009-2010 period, published this report that was just as clear as it could be. We're not prepared. We've got to get prepared. Margaret Chan at WHO put forward a proposal saying we need $100 million for pandemic response, and it was rejected. It was rejected by the World Health Assembly. Margaret did try to respond to this report, and it was frankly rejected. So if you look at health expenditures in these three countries, we're not serious. This is not a serious effort to protect this population and protect the entire world from epidemics. Now, Larry Summers and Dean Jameson recently published another paper that looked at the estimated annual global cost of a moderate to severe pandemic, and if you annualize it over a longer period of time, it's $570 billion a year. So in fact, there is a real cost. Just like in climate change, there is a real cost to putting carbon in the air. It's just not yet reflected realistically in the market, which is why we're working so hard to put a price on carbon. But if we had the big one, a severe flu pandemic like the 1918 pandemic, it's 5% of global income, which is about $4 trillion, right? So we're facing a potential $4 trillion disaster. Ebola, which is slow-moving, nothing like influenza, which is slow-moving and was mostly limited to 3 countries, cost us $10 billion. Right? So I want to put these figures in your head because there are people asking, is the insurance too expensive? You have to ask, too expensive compared to what? Compared to not having an insurance instrument, compared to having to wait until legislatures make decisions about providing financing to stop pandemics, which we're experiencing right now in several places in the world. Legislatures are not set up to effectively and scientifically and in an evidence-based way respond to pandemics. So we really felt that we had to bring experts to the table, along with people who had an incentive, whose incentives were completely aligned with stopping a pandemic. The insurance industry, you have to remember, is highly incentivized to stop a pandemic because not only do they hold life insurance policies, but they hold the business disruption policies. Right? So if a pandemic occurs, and even if the loss of life is not that great, travel stops. And companies lose business. And so the business disruption policies are also a great concern for insurance. So we had a situation in which truly the incentives were aligned. But let me stress, this was not easy. This is a widely known saying, the infectious disease outbreaks are inevitable, pandemics are optional. And the financing facility that we've put together is very specifically focused on 3 different classes of viruses: the flu viruses, the orthomyxoviruses, the filoviruses, which are AIDS, and the filoviruses, which are the Ebola and Marburg, and then also the coronaviruses, SARS and MERS. But what will it do? It will be focused on the 77 poorest countries. So the world's poorest countries, our IDA countries, will be the beneficiaries of the instrument itself. There will also be a cash layer, a $100 million cash layer that can be used anywhere in the world, and not just for the 3 diseases, but for the $500 million insurance policy / bond that will be focused on the 77 poorest countries. It will release funds quickly, and I'll show you a diagram for how this will work. And the idea is to release it quickly so you stop a pandemic early, and I'll show you how that would have worked in Ebola. We think it's going to save lives by financing a much more coordinated, much more aggressive response. Just putting the instrument together forced us to talk with all the different responders in the world, and now we have a group of both UN system and NGO-based responders who we've now in the middle of agreeing on things like who's going to do what, how are we going to, for example, leverage the private sector. WFP, the World Food Program, who played a fantastic role in Ebola, has now gotten an agreement with FedEx, with DHL, with all the major carriers that in the context of a pandemic, those companies will immediately jump in and help. The problem during Ebola was that none of those agreements had been made ahead of time. Everyone was worried about liability. Everyone was worried about, well, how's this going to actually work? We're even negotiating now administration fees so that when this money moves to those first responders, how much we'll pay in administrative overhead. It's going to reduce costs. And again, I'll show you this. I'll make the case with Ebola. And I think that maybe if things go as we hope, the most important thing is that it'll get all of us thinking about pandemic preparedness. What's happened so often is that we go through periods of total panic and then periods of complete neglect. And it just goes up and down like this. When I was working with J.W. Lee, who was Director General, who was the newly elected Director General of the World Health Organization, I was in charge of dealing with the end stage of the SARS response. And I had several companies that were working in China, and they came to me and they said, okay, we have now put together $300 million that we're going to give you right now. We're going to give it to you right now because we want you to stop this from ever happening again, because they lost so much money from the travel restrictions on China. And so my response was, well, we actually don't have an instrument. PAHO has an instrument to accept donations like that. But at that time, WHO did not have an instrument. So in the process of trying to put together the instrument, which took us about a month and a half, by that time, SARS was over, and the $300 million was off the table. Right? So that's what happens, and it happens every single time. Panic, neglect, panic, neglect. But with this pandemic facility, we've been working at this now for over a year and continuing to try to understand, so how will the response actually happen? We think that what will also happen is to create a new market for pandemic risk insurance. The insurance industry is actually excited about this. At the most difficult periods, when everything seemed too complex, what the insurance industry kept saying to us is, well, you know, every new market for insurance is messy just like this. And they gave us as the example the car industry. They said, you know, when we started with automobile insurance, we didn't know that seatbelts were helpful. We didn't know that shoulder harnesses were even more helpful. We didn't know that airbags were even more helpful than that. And we didn't know that speed bumps also were helpful, because the incentives were aligned in the automobile industry. And what they're telling us is that as they work at this, we'll get better and better and better. We don't yet have a globally agreed upon measure of preparedness. But guess what? That's what we're working on right now. We've got to get there so that this makes sense in the market. We hope that middle-income countries will begin to purchase pandemic insurance, because what it will mean is that since we know what it means to be prepared and not prepared, since we will eventually, we think, have very good ways of measuring preparedness, that premiums will go up and down depending on the level of preparedness of a particular country. And you know, it's going to take time, and the first few times that it releases and people see the benefit of how having financing and a coordinated response earlier, as that becomes clearer and clearer, I think this will develop into a real market. So what is it? It provides up to $500 million in coverage to IDA countries, but as I said, there's also the cash window, which is right now it's over $50 million. We've already have pledges of over $50 million, but we think it's going to be around $100 million initially. And the cash window will be not just for the three diseases, but for anything in any country in the world. And there are, again, certain responders. A lot of this money, I presume, a lot of it will go to WHO, and they have their own contingency fund, which is to run down any possible thing, and they're already using their contingency fund for things like yellow fever in Africa. But this also will be a completely unfettered cash window that we hope will release that will be used very early on, so that even if it's not a real pandemic possibility or a major epidemic, that we'll be financing the capacity to go and snuff this out early on. The coverage will be sought through the World Bank, and we will issue a pandemic bond. Now, we have a lot of experience with catastrophic bonds, and catastrophic bonds are simply, we go to the insurance markets, and we have done this on behalf of countries. There's a Pacific group, there's a Caribbean group. And what it is people actually put cash into a bond and they get a coupon, they get a certain percentage back every year. But then what happens is if the cat bond has to be dispersed because of a particular catastrophe, they lose that portion of their own initial investment that was dispersed to respond to the catastrophe. Now, they continue to get the yearly payments over the length of their commitment, but they lose some portion of the capital that they put in. Now, we actually went to the markets and we did a lot of talks with people who could potentially buy it, and what we found was tremendous interest. Partly because there's not a lot of return in other sectors. There's negative interest rates, as you know, in many parts of the world. So there's plenty of interest in purchasing this bond, and it will be the key part of it is that it's going to be more or less about $300 million was going to be the pandemic bond, and $200 million of a straightforward insurance policy. The key to this, though, is that this is not the usual claim-based insurance. You don't wait until something bad happens, a claim comes in, and then it pays out. It's actually a different animal called parametric insurance. Not claim-based, but parametric. In other words, when certain criteria that are based on the size, the severity, and spread of this particular event, once those triggers, which we spent a lot of time getting right, once those triggers are activated, the bond will release. It's not something that you wait until after a pandemic is over and then you pay all the claims. That's not how it works. The whole point of it is to do it as early as possible. And this is something that's really new, certainly new for global health. So if there's an insurance part and there's a cash part. So if an outbreak is escalating and the threshold for the insurance window is reached, the third-party verification will happen within 48 hours. The country will request the funding to the pandemic facility. The money will be released immediately, both to the country and to designated responders, and we hope with an expedited response. But if it doesn't reach the criteria, then what will happen is that the country will make a direct request to the pandemic facility. There'll be confirmation from an independent group. The money will be released again to the country and responders, and again, an expedited response. This was the crisis in West Africa, and this is how the money came in, right? So it didn't really peak until December of 2014, fully a year after we knew about this crisis. We made our first commitments in right here. We made our first commitments on August 4th of 2014, when it was still relatively small, but the dynamics of it were very, very frightening. If the pandemic facility had been around, 100 million would have been available immediately, fully 3 months before the first major tranches came online. Now, timing is everything. So this was the actual Nigeria case, right? Again, brilliant response. Huge kudos to both the Nigerian government. President Jonathan told me the whole story one day we were at a meeting. But huge kudos to the Nigerian government, but huge kudos also to CDC. CDC played an extremely important role. But we did some modeling and asked the question, what if we had waited 50 days instead of responding at 3 days? Those are the different potential scenarios in terms of number of cases, and that's the median, right? So 50 days is a huge amount of time in pandemic response. And the 3-day response was great, and our hope is that the cash window would have been flowing immediately if it was needed. Right? There's a lot left to do. The countries have to create response plans. They have to strengthen their capacity. They have to make investments. WHO has to benchmark it. We've got to think about ways of measuring preparedness. We have to improve data. Responders have to be coordinated more effectively. And again, that's one of the things that's happening with this facility. We need to support investments in health systems. We've got to build the health systems on the ground that will allow countries to respond more effectively. We have to involve the private sector. And again, the private sector's incentives are not always aligned with global health goals, but in this case, we're very lucky because they're perfectly aligned. We're already working on frontline health workers. This is going to be the key. We're going to have to build those systems capable of responding. We're working in Liberia. We're sponsoring health workers in Ethiopia, in Nepal, community health volunteers. We're building the program. Here's how we're thinking about this idea of universal health coverage. Still to this day, finance ministers and heads of state and heads of government are reluctant to utilize even IDA, our fund for the poorest countries, which is 0% interest over 30 years with an additional 10-year grace period. So it turns out IDA loans turn out to be about 60% grant. And they're still wary of using IDA loans for investing in health services, for example. And part of the reason is because they think of it as just an extra cost, that any time they have IDA money, they want to invest in what they call hard infrastructure, roads, electricity. You understand that because they need those things too. But we think that building functioning health systems, in my experience in doing community health work, it's not doctors and nurses that are the key in many of these countries. It's really the community health workers. And if the community health worker programs that will be the foundation of UHC could help us with non-communicable disease outcomes, communicable disease outcomes, help us with pandemic response, help us with response to stunting, and also be an employment program, a job training program, a way of bringing otherwise unemployed young people into the formal labor market, if it can actually be a creator of jobs, and as we found with our conditional cash transfer programs, even local fiscal stimulus, if it can be all those things at once, then I think that ministers of finance and heads of state and government will look at the potential of UHC very differently, because it's probably going to be good for getting votes as well. Just leave you with the idea that there is really, really such a thing as being too late. And Tom Frieden, I know, has been giving talks, and he's absolutely right, that days and hours in epidemics matter. So the time to act is now. We're very grateful to the Japanese government. We just heard from the German government that that they'll make an additional, that they will also make a contribution of at least 50 million euros. So I'm 100% confident that before the end of the year, the pandemic facility will be functional. We will find the funding to go for the first 3 years. And we hope that the impact will be so clear, if it never dispenses and simply forces us to organize, forces us to get clear indicators for preparedness, I think the value of it will be so clear that we will continue with it. We use this figure that there are 400 million people worldwide who lack access to essential health services, but anyone who's traveled knows that the figure is much higher than that the number of people who have access to really quality health services is much, much higher, multiples of that number. We need to lift our ambitions. We need to break these mental models and understand that tackling HIV/AIDS, child deaths, nutrition, that tackling these issues is directly related to economic growth. It's the right thing to do for people, but it is directly related to economic growth. I'm trying to get to a point where progress on stunting will have an impact on our estimates of potential growth. That progress on stunting will have an impact even on foreign direct investment or maybe even bond spreads. I don't know if it'll go that far. But we now know Peru, after not being able to reduce their stunting level, they were at 30% for decades, and they were trying hard with a combination of a payment for results instrument linked to a cash transfer program that was contingent on families doing the right thing with their kids. They reduced the stunting rates from 28% to 14%, cut it in half in just 8 years. So we know it's possible to cut that rate. We also know it's going to be critical going forward. Lots of stuff to do. The private sector, national governments, international assistance. Financing for universal health coverage is going to be a different animal than the way we've thought about it before. It's not just going to be dividing up ODA. We've probably hit a peak on ODA. I don't see governments increasing their tax rates. I don't see governments being excited, other than the UK, about increasing foreign assistance. We have to use leverage. And insurance is the original leveraging machine. Pay a small amount now and get a large amount later if you need it. This is the man who said there is such a thing as being too late. And there really is a fierce urgency of now. I mean, the first case of microcephaly in the United States just happened, I think, this week. So, and just to make the point on Zika, we provided $150 million of support to countries that asked for us for Zika. But the cash window would have been available to look carefully at the Zika problem early on, and I hope may have had an impact. This is a tough one. Zika is a tough one. There's no question about it. The Aedes aegypti mosquito is a formidable foe, but we have to act now. The pandemic facility is a small part. I hope I got that clear, of a much larger project, and we look forward to it because this is new. This is different. We've got to make sure that we bring it to conclusion, and I think the end result will be many, many, many lives saved. I think this will be tremendously important for the Global Health Security Initiative that's being managed and led by the United States. And this is what financial institutions should be doing. We should be looking all over the world for innovative financial instruments that will help us to protect poor people, that will help us to stop epidemics early on. This is what we're trying to do at the World Bank Group, and I look now forward to having a discussion with all of you. Thank you.
Thank you so much. Can you see us over here? Let's move this back a bit. Well, thank you very much, Dr. Kim. It's very impressive how much this concept grabs your passions and how much it combines the different facets of your life and your career. I mean, you were reaching all the way back to earlier days at Partners in Health, earlier days at WHO, in experimentation and transformation of approaches and the like. I want to focus just quickly on some of the issues around making this successful, the Pandemic Emergency Financing Facility. We know that velocity is going to be a key factor. The speed of response, getting the mechanism in place so that is possible. And I would think that of the things that would keep you awake at night, that would be the lead element that would be of concern. Can you build this so that you do get true speed of response? Can you say a bit about that?
Well, it depends on the bug. I mean, the flu pandemic is just going to move so quickly that I don't think this instrument is sufficient preparation for a flu pandemic. If you ask very simple questions about the flu pandemic, what if we had an effective vaccine? Do we have the facilities in the world today that can produce the vaccine quickly enough to have an impact? And I think the answer still is no, right? So are we incentivizing R&D on vaccines against the fast-moving viruses? I think the answer still is no. And Zika is an example of what we fear the most, which is Zika. In the case of Zika, it's an old virus acting differently, right? And of course, the biggest one is a new virus altogether that acts in ways that are extremely destructive. The chance of that happening is very high. So it's not enough, but at least it's something. And people keep asking, well, it's too expensive? And I have to keep saying, compared to what? Compared to what? Is there another pocket of financing that is looking specifically at preparedness, making arrangements with responders, trying to get ahead of an outbreak, even for any disease at all? I mean, do we have that system anywhere, and how would that work? Right now, it's us, it's the U.S. government, it's other donors, but we see that putting out sufficient resources to respond to a pandemic, even in the wealthiest countries in the world, can become political. We have to find a way to take it away from the political realm.
Now, it involves roughly $50 million a year in cost over that 36 months. So you're getting the $500 million, you're getting the $100 million cash window with a $150 million investment over that period by the key donors. You're in the process of going out and raising those funds, and you're making progress, and presumably in the next several months you'll have that. And the premiums will be paid by donors for the IDA countries. Is your vision to move this so that countries are paying so that the premium rates drop over time, and that you convert to where the countries themselves are beginning to pay for this?
Yeah, I think it will always be difficult for the IDA countries to pay those premiums. But I think that once we refine the instrument, once we know better the levels of preparedness. I mean, I think that part of it is that we're going to have the courage, maybe along with the insurance industry, to publish data on preparedness. And I think that this is something that will create a lot of concern among the public in middle-income countries, for example. Wow, we've just learned that we're completely unprepared, and there's a possibility for us to purchase insurance. Now, I think pandemic insurance could work in any country in the world. I mean, Tom Friedman's talking about $5 billion, whereas it might be difficult to get all of that in cash up front. Maybe we could agree on paying a premium for the possibility of having access to that when you need it. Now, there would be a lot of negotiations and there'd be a lot of discussion that would have to go into that. But again, it is in the interest of the insurance companies to stop pandemics in the United States. Probably the biggest holders of business disruption insurance are companies in the United States.
Right.
Yeah. So I hope that this becomes a real industry. I mean, early on, I don't think everyone thought that fire insurance and auto insurance, all these things would become as ubiquitous as they are, because it doesn't make sense. And I have to really take my hat off to Nicholas von Baumhart of Munich Re and Michel Lies from Swiss Re, because they really pushed it. There were times when their own companies were saying, this is so complicated, let's just stop. But they kept pushing it. And I had a discussion, Michel's retired, or retiring soon, but he came to see me and we talked about this, and he said, we haven't done a good enough job at explaining the power of insurance. Right? And Mark Carney, who was the central bank governor in Canada and now is the governor of the central bank, the Royal Bank of England, Mark said that one of the things that we have to rediscover in development work is the power of insurance, because it is leverage. It is leverage in the purest sense, and I think we don't use it enough.
I would expect that you're going to need to demonstrate that it's possible that an insurance instrument can apply to a pandemic threat that could come from anywhere, right? I mean, when you're putting catastrophic bonds together for climate change or for natural disasters, you can focus on regions that have a shared vulnerability that's been proven over and over again. Here you're dealing with something that is much more globalized. It's not concentrated necessarily regionally. And so the threat may pop up and really be just a single country, right, rather than something that's a consciousness within an entire region.
Right.
You say a bit about that?
So the hope, of course, we're starting off with $100 million in the cash window, but we hope that grows, because then that's the window that will really be available for anything, anywhere. And I think we're going to have both. I think we're going to have defined insurance for specific outbreaks, but then the cash window. But the hope is this, that when you purchase the pandemic bond, you know that it's capital at risk, that if all of the $300 million is dispersed, you're not going to get that. You're going to get your coupon over the next 3 years, but you're not going to get back the principal that you put in. But what we hope is that for most outbreaks, that because we have the cash window, and because the insurance part of it will be more focused on the more frequent kinds of activities, that at the end of 3 years, we may have dispersed 10, 15, 20, I don't know how much, but we would have done it in 3 villages to stop something before it started, right? And so I think that's what's going to prove the effectiveness of the pandemic facility, is that we're now going to support WHO, PAHO, all these other agencies to get out there and there. During Ebola, there really was a concern about resources. There was a concern that there were not the resources to be able to respond effectively. That has got to go away. We've got to get rid of that altogether. And these agencies that are charged with hunting down these epidemics have to say, in this case, money is not the problem anymore.
Yeah. Well, what we saw in Ebola, and I think this is very relevant to this new facility, is that from multiple directions there was huge hesitation to decide to act. And that came from worries about the investment and trade disruptions. It was the political pressures that came to bear upon the WHO Emergency Committee. It was the memory of perhaps bad decisions that had been made 4 or 5 years earlier that had washed back. So all of those political calculations are going to come in as you put together the committee that's supposed to be the decision-making mechanism. I would think you would be subject to many of those same kind of complexities. Yeah,
I think these things are always political, but my own sense of it is that first of all, I think one of the discussions we had early on in our involvement in Ebola was how aggressive should you be in utilizing the international health regulations, the IHR. And I was there. I was there in 2003, 2004 when we were redoing the IHR. And the reason we redid the IHR is because we didn't think it was robust enough, because certain countries hid cases, right? So we made it more robust. I think the Ebola experience, I hope anyway, has convinced us once and for all that aggressive investigation is not something that's an option. We have to do it. And I think that if there is the sense that there's an automatic dispensing of resources, that there will be less hesitation. And what we will tell every single country in the world is the most important thing you can do is to scream that you've got a problem as early as possible, because now there's financing, there's a coordinated response, and let's stop it at 3 villages instead of turning it into an economic fiasco, an economic and human fiasco like Ebola was in those 3 countries.
Okay. Let's chat for a moment, and then we're going to turn to our audience just about how this relates to U.S. approaches. The U.S. is not, is not expected to make a major cash donation. You referenced that country assessments of their preparedness will be very important in raising consciousness of the vulnerabilities and requirements. The Global Health Security Agenda is putting a big emphasis on that. Say a bit about how this facility, this one slice, fits in your mind, in terms of the U.S. approach on building capacities post-Ebola,
Well,
and what are you looking for in terms of support from the United States?
Well, first of all, we're in constant communication. I mean, Tom is an old friend from TB days. We worked together on tuberculosis, and so Tom Frieden, and so we're constantly working very closely with CDC. But let's look at the benefit it might have had if it were in existence prior to Ebola, right? So the U.S. spent more than $1 billion on responding in Liberia. The Liberian health minister said, now I'm not sure if this is true or not, but the Liberian health minister told us that if this had been in place, the Liberian situation would have been completely different. Right? And so I like to think that would have been true. And first of all, what would have been different? First, even if it were today, the coordination among responders is much better than before. The willingness to go into a situation knowing that there is now economic support is much greater than before. Once we get this online, there should be no hesitation at all. And that, at the end of the day, will have a huge impact on the United States. I mean, the U.S. can control its own borders. It can control what happens inside. It does a lot of work in many countries in the world to try to prevent these pandemics. But I think it will be a very strong piece of support for the Global Health Security Agenda. It's not enough. There's still a lot more that we have to put in place.
Let's collect. We're getting to the end of our hour here. We're going to take 4 quick comments, single interventions, please. Then we'll come back and then we'll close. Yes, right here, and right here, and here, and here. I apologize to those that we're not reaching, but we're at the limit here. Yes, please. Please identify yourself and be very succinct.
Hi, my name is Allison Neal, and I'm here representing Henry Schein. First of all, thank you so much for this session, but more importantly, everything you've done to really change the world, as you said. And we at Henry Schein, we've been our chairman at the World Economic Forum. We're serving as the private sector lead in this global supply network for pandemic preparedness and response. So we're partnering with the World Food Program.
That's great. Yeah.
Your cousin and her team. We brought in the World Health Organization. We're working with your colleagues, UNICEF, and then we brought in private sector companies, Becton Dickinson, Johnson & Johnson, UPS, to serve as a logistics partner. And we're in the process now. We were able to get from the World Health Organization the list of critical products that they would need in times of
that's
pandemic,
great.
the top 10 pandemics. And we're now steadily going through that list and finding suppliers who manufacture each of those items. But it's still very complicated, right? Because
Please, we need to move on.
Yeah.
anyway, we're very eager to engage with
That's
the
great.
Bank.
Great to hear.
I think it's very important.
Thank you. I'm not sure if your microphone's working. Was that working?
I could hear her.
You could hear, yeah. I mean, we could hear you, but I'm not, for broadcast purposes, we've got to be sure the mic's working. Okay, right here, please.
Hi, my name is Kobayashi from JICA, Japan International Cooperation Agency, and first of all, congratulations on the launching of this facility. I think it's a very big shift from what you termed as the past the hat financing. So very congratulations. One thing that I wanted to ask you about your take on this threat of AMR, which was one of the pillars of the G7 agenda. What you think is the risk and how World Bank is going to respond to this risk?
So first of all, let me just say that I'm so grateful to the Japanese government. I mean, it got to the Prime Minister Abe himself really pushed to get this done. And I think it was done quicker because of Prime Minister Abe and Deputy Prime Minister Aso's support. And of course, we just did this deep dive with JICA. But you want to go to the other? I'll talk about AMR.
Finish your thought,
So
and
look,
then we'll
AMR
get
is
to
a
two other.
huge issue, right? And I'm seeing Marcos Espinal, my buddy from drug-resistant TB days. We knew this for a long time. And the reason AMR is so hard is because the incentives are not aligned, right? We would like to have the major drug companies who are the best at coming up with new molecules involved in this, but the incentives are not aligned because the minute you get a new antibiotic, you have to restrict it, right? So what is the cost of the antibiotic, of a single dose of an antibiotic that you need to get to have an actually market-based incentive? It's literally in the millions of dollars because it will be so severely restricted in every formulary. So we've got to figure out a better way. And at the G7, I actually talked with Prime Minister Cameron, who this is a big concern of his. And I think we have to be very creative. Is there a possibility of a bond? A sort of a superbug bond, where once the drug is brought to market, that the drug companies can sort of walk away from it, and that the people who purchase the bond will be the one. I don't know the answer. We've been working on this. There's DNDI. We've been working on this forever. The Gates Foundation has had huge success in bits and pieces, but on this one, the problem is that the incentives aren't aligned. So we have to think about this in a completely different way. Yeah.
Thank you. You had your hand up? Yes, please. And then over here. And then I apologize, we're going to take two more, and then we're going to close. Yes,
Okay.
please.
Hi, good afternoon. My name is Stacy Wood. I'm a Department of State Foreign Service Officer on detail to Amazon Web Services. My question is, what do you recommend as the first step for tech companies in particular who have solutions to help with early warning signs and disaster prevention and response and mapping and things like that?
So real quickly, after Ebola, I was having dinner with the head of Vodafone. And he said, we had cell phones in a box. We could have given them to you, but nobody called. Nobody asked us, right? So it's just what we heard earlier. We now have to make prearranged agreements with all the tech companies and figure out, what they can do. And my understanding is that conversation is ongoing right now. But anyway, we need to figure out what it is that's needed from the tech companies. How we can, for example, use social media. How we can use smartphones. And then when the plan is ready, we will have all the prearranged agreements, all the sort of, you have to have things like, what are they called, indemnification agreements, all aligned ahead of time. We think that the pandemic facility will be part of putting those together.
Okay, one last comment, please. Aristo, thank you.
Thank you very much, and congratulations. My name is John Hassel with AIDS Healthcare Foundation. Dr. Kim, would you kindly address the problem of the bank's definition of a middle-income country, the MIC definition, which is used in determining eligibility for Global Fund assistance for lower drug prices and the AIDS response? It's used for the bank's purposes, but other groups use it as eligibility requirements that eliminate some of this assistance for middle-income countries. And thank you very much.
For us, it was not put together with the intention of making countries unqualified, disqualified from receiving grant-based funding. We do it in order to determine who is eligible for, what kind of level of concessionality. So I actually don't know the answer to the question in terms of what's going on in these other agencies, but we're certainly open to having a discussion about how our criteria affect. Right. So I don't have an answer for you. Right.
I apologize. We've gotten to the end of our hour, and we do have to stick to schedule for a couple of reasons. So please join me in thanking Dr. Kim. Congratulations.